Good. Alrighty, everybody, welcome back to another episode of your favorite podcast, the Sports Medicine Project. Now, I say this every episode with every single guest, but I'm an extra bit excited today because we have Andy Bryant on the podcast. Mate, how you going? Thank you so much for coming on.
I'm well, thanks for having me.
Beautiful. So whereabouts are you at the moment? You're down south, aren't you?
I'm in Melbourne, and I'm really busy, and I'm coming up your way, like past where you guys next week. So I had people that cancel, and I usually try and fit them in, but decided to work a Saturday instead, and it's a bit quieter here to do a podcast as well.
Yeah, the clinic room, a bit like a studio room, isn't it? The clinic room,
yeah.
It'd be nice.
Yeah,
beautiful. So, mate,
that in Melbourne, yeah.
Yeah, for the listeners, can you give us a bit of a backstory as to what you do, who you are, and I guess the journey that you've been on and still on?
Yeah. So I think I got into podiatry because I was a runner when I was at uni, and like an elite level runner, but plagued by injuries. But podiatrists weren't treating me then. I only started getting treated by a podiatrist once I started podiatry school. And you all make each other orthotics and then staying them for like 20 years, which is what I did. And then got into private practice pretty quickly, although I, at the time when I was at uni, didn't think I'd enjoy working and had a passion for teaching. And so I did an honours year, which was a teaching year as well. And I really enjoyed that. But then I started working, and it was just so easy to work. And, it's a lot easier than uni life, I think, to be working in some respects in terms of finances and things. So then I got into private practice in a partnership for, I think, 18 years. But the last 3 years, I started changing the way I was practicing, and a few other things were coming up, and it's probably harder than a marriage to be in a partnership. So I ended up bailing on that, and we had multiple practices. I got one little one where I am now, and that suited me fine. And yeah, so the last 3 or 4 years, I've been exploring a different way of treating my clients. It's just still evolving.
Yeah, incredible. So, and I mean, talking about over the years, so obviously when you went to podiatry school, we were very much treating, I guess, the kinematic model of, foot rolls in, plastic underneath, make it neutral, subtalar going neutral, all that kind of thing. So you trained and, I guess, grew up with podiatry when that was, I guess, what we thought about everything?
Yeah, so although I had Craig Payne as my honours year supervisor, and he was the lecturer that I most, you have got an affinity for a lecturer because you like the way and he was really pro making us think and using all these different, and just as long as you could justify why you were thinking a way using some model of care, and the tissue stress model was always my go-to. And even when I was in the other private practice, we had our own little lab, and I was probably known as an under-prescriber of an orthotic. I think because I was generally lazy and I had to make it myself. But also it was still always using that tissue stress model. Okay, this is loaded, let's unload it. And so I think I still have that at the core of the way I work. And I think that will answer one of the questions as well further down the track. But that's was always my sort of modus operandi, and we were explained that then, the tissue stress model, but there was still a whole lot of this way of the foot moving is wrong, and we need to move it to this way. And if anyone you saw, you were trying to get to be this perfect foot, and I now, in my age, when I'm speaking to someone, when I'm watching them walk, I'm explaining to them, I'm not seeing if they're this far away from the way they should be walking, or I'm just getting a feel for how they move and how that might be loading tissues. And then how does that relate to what's actually going on? I'm not saying it's bad or wrong. I'm just trying to see what they're doing and then how that relates to what they're coming to me for. Yeah.
Andy, you said that you experienced a few running-related injuries before you got into podiatry. Do you think that how that was managed and how you got through those injuries has influenced, some of your treatment philosophies now and when you were becoming a podiatrist?
Yeah, for sure. And they were mostly medial tibial stress issues and stress fractures. And it was like I was an elite junior, running nationals, that type of thing at middle distance. And I had a coach that was really Arthur Lydiard, the long, slow distance, build up your base. And to become a senior athlete, you just have to do more Ks. And really, that probably didn't suit me. I kept getting injured. And then I got Steve Ovet's coach. And I don't know if you know those guys, Steve Ovet and Seb Coe. And the Seb Coe was really about technique and gym work and speed. And Steve Ovet was this grinder, and they would meet together in the 800 and 1500 meters and have these massive So I got Steve Ovet's, the wrong coach, the wrong side of the stick, because that was another guy that just ran me into the ground, and I just kept getting injured. And so there's nothing wrong with the way my foot moves, but I think when you add all that load to the way I was running, probably, and I probably became a plotter rather than a really, like, my technique probably changed as well. And so putting an orthotic in there wasn't going to help. I never did any mobility work, any strength work. We were worried about, 20 years ago, I was worried about strength work. I didn't want to get bulky as a middle distance runner. But doing 100 Ks a week, it's almost impossible to get bulky. And so, like, if I look back, I'm like, wow, if only I'm sure we all do that. If only I knew then what I know now, then who knows what I could have done in my running career. Like, I quit running for 20 years, and I guess, and then I became an elite cyclist. And through a series of falling off my bike and head injuries, I found yoga, and my own feet started to change massively. Like, for the first time, I stopped needing to wear my orthotics. I thought I needed to. And my feet were getting more mobile. My whole body was getting mobile. I started going to a gym and training and seeing other people train barefoot. I'm like, there's got to be something to this. And I started running, but getting old symptoms back. So then I was looking to running technique, running shoes, like just using my body. And Nick from the Foot Collective probably taught me this, using my body as the first experiment, just seeing, okay, what works for me, and then how do I apply this to other people? Not exactly what I'm doing, but, you know, okay, how am I loading this? How can we change this load? That type of thing. So definitely my own experience is continuing to shape what's going on. Even the people around me, like my wife has a sore foot now. And so I'm like, okay, so why is this happening? And how would I have treated this before? And when, you know, like, you're just constantly in your head about this stuff. More than ever before, actually.
It's so interesting.
Well, we'll get cracking with this first question. I guess what I would have liked is, you know, we've got the overarching principles to how you treat. And I think we all inherently have our own principles, whether or not we reflect on them very regularly. But people can see the barefoot content as polarizing, you know, where people say pain is caused by wrong fitting shoes and all that kind of thing, and then associate that with you as a person. And we know there's more nuance to it than that. So for the listeners, what would you say your principles are for your way of practicing? Now, forgive me, when I say barefoot, I just think that people will know that group. I'm sure there's a better name for it, but
and so you might say pro minimalist shoes, or and I guess there's not many podiatrists this way aligned, and that's why maybe what I'm saying is a bit more like out there, because most people align podiatrists with big shoes and orthotics and things like that. But there are other podiatrists doing what I do, but maybe less vocally. And so I think it comes back to what I said before, this idea of tissue stress model, and it's not, and that probably on social media, it's far more black and white than it is in reality. Like, when someone's coming into me, I'm assessing where they're at that moment in time, where they're coming from and where they're going to, and putting something in place that is going to suit them there and then. It's not like everyone is just going into a minimalist shoe. And so I would say my overarching principle of practice is to meet people where they're at, listen to them. They mostly got the answers for you. And I think I have a very nuanced audience now, in that people that come to me want to be going into a more natural way. They've had experiences with orthotics, or don't want to go down that path, or with other modes of treatment. And they've either heard about me or researched about the way that I work. And so, and they're often highly complex cases now, like they've shopped around, they've done a whole lot of stuff. And so just to actually meet someone where they're at and acknowledge that, and then move on, it's move on to the next step. It's hardly the barefoot principle to some extent, because but then I'm also looking at them as a human, and as how a human should move. And often so much has happened to them, not only their feet, but their whole body, because of westernized society in terms of footwear, office jobs, so much stuff going on, that when we peel this stuff back and go back to being a more natural human, and giving your body the chance to heal, the opportunity to heal, whether that be with more strength or rest or other, good diet, sleep, all these different factors. When we start peeling all that back and having someone understand, or seem to understand, or acknowledge that they have pain and injury, I think this is my overarching principle. And maybe 2 years ago I would have answered it differently. I would have been like, no, everyone needs to be in a barefoot shoe. I just think it's more about letting their bodies do the job, and finding where they're at that moment. I don't know if that even answers the question.
That's good. That's really good.
Andy, what are the more common pathologies that you do see through that, complex caseload that you just mentioned?
Yeah, well, a perfect example yesterday was a lady with a bunion that had traveled from like probably 60 kilometers away to see me, because the chiropractor that she traveled 70 kilometers to see told her to come and see me, because she'd already got orthotics for bunions.
Yeah.
She's starting to get claw toes, and she's got met domes in her runners to help her claw toes. So this is all like putting a patch over things. And the orthotic was totally inappropriate, won't even fit in her shoes. And so, and it had been revised 4 times, but still didn't really fit in her shoes, and it wasn't comfortable. And so, so I see a lot of people with bunions in this situation where they've done all this stuff and they've still got a bunion and they're still having issues with it. And so I said to them, has anyone talked to you about your footwear? And the footwear has not even come up on the radar. Like, it's not even a thing. And so I pulled out the insole of her shoe, of her runner, her most comfortable shoe, and put her foot on it, and her toes are crunched like this in her runner. And so, like, that's a pretty powerful image for her to see. Like, this is the shape your foot's meant to be, and this is the shape it is now when you're in the shoe. And so, like, for her, it's just about getting her head around wearing a different shoe, and some very basic exercises. And maybe in 6 months' time, when she's come to that point, she'll come back to see me. But a lot of the pathology I see is heaps of bunions, a lot of chronic heel pain, because a lot of stuff hasn't worked, and then some really, like, have an hour and a quarter for initial consultation, and some people just need to speak to me for half an hour about the history of their feet, because there's so much stuff going on. And in those cases, I'm just going, okay, what's hurting you today? What's hurting you this week? What's hurting you this month? And let's work on that, and then see how it all falls into the bigger picture, like just decreasing goals and things.
Yeah, like talking about bunions, and it's such a controversial topic, because there's genetics, there's shoes, there's this, there's that, and we try to explain it as a whole spectrum of treatment. There's lots of things that you can try. Like, what's your take on them, and kind of their etiology, and also how do you explain them to patients as well, like the analogies and things that you use?
So I definitely would say that I start out by saying there are genetic factors that have predisposed you to having this happening to your foot, and then there are environmental factors as well. And it's when those two coincide that we end up with a bunion. And that's in a perfect world. Like, some people don't have the environmental factors and might still get a bunion. Some people don't have the genetic factors and still get a bunion. But I think the genetic factors are, and this is how I explain it, are triggered by the environmental factors. And it can't, if you go to any local kindergarten, there are 99% of children, possibly 100% of children, in shoes that aren't widest at the tips. And the message when those kids were first walking was to have a shoe that's widest at the tips, to have a shoe that's thin, flat, and flexible. But when they go to kindergarten, when they're 2, 3, or probably 3, 4, 5, they're in their little shoes that are squishing their toes. And so if they have a predisposition to having a bunion, that's a very early start on a very flexible foot to start changing that. And so, and then, I mean, it's a given amongst all the podiatry community that a really pointy shoe and a high heel increases the chance of a bunion. That's a given. So it's not that, I don't think it's that big a step to say, let's go back a step and say that any shoe that is squashing your big toe sideways may be a precursor to a bunion as well. It may just not be as big a precursor to a bunion. But if you're going to say that a really pointy shoe is going to help trigger a bunion, then any shoe that is pushing that big toe sideways is going to have an effect on the mechanics around there. But obviously there's stuff going on up the chain. There's so many different factors, and I'm assessing someone for all of that and working out what individually is the issue.
I like
but, can I just quickly say, if we don't change the shoe, we are just like moving deck chairs on the Titanic. Because if you don't change the shoe, you can put the toe spaces in, you can do all the foot strength, you can do all the mobility, you can do all the core strength, hip strength, all this type of stuff. If you keep putting your foot in that environment 8 hours a day, it's like, you're on a hiding to nothing. It's very hard work.
I like that you've said, just, it's not, and I think that the social media stuff can be polarizing for people, because they see it and I think they take it as the community and your community saying shoes cause bunions, full stop. And then obviously, like you said, social media is black and white, but you're not saying that at all. You're saying it's a it's an increase, maybe a risk factor. We don't know how much. It could be a lot, could be less, but it's more meaning the person individually and seeing where they're at. The shoe may play a big role, or it may not play a huge role, but it probably is in there somewhere.
Yeah.
Yeah. How and I feel like I'm going controversial topic after controversial
Good.
topic.
That's what I'm here for.
How do you use orthotics in your clinical practice, and what general advice do you give with them?
So I mean, I've got a lot of history using orthotics because I used to make them myself, which gives you a real insight into how they work, I think. But I never had a great feeling about them. Like I was always like, oh, I don't want this to be something I just rely upon, But then I had clients in them for 15 or 20 years. And the hardest part of me changing the way I practice is when that client comes back for a recover or because they think they need new ones or whatever. And me explaining that I have changed the way I practice and they may not need them in the long term. But mostly it's a very positive outlook because people inherently trust their provider. Do you know what I mean? And so I'm not abusing that trust. I'm just saying there's another way. And some people are like, you know what? I love my orthotics. I'm going to stick with them and that's fine. But I tend to not see those people so much anymore. Like I'm not even set up to do much orthotic work. I've got a podiatry practice just up the road here that like maybe 5 kilometers up the road. And the husband and wife were at uni the year below me, and I use their lab. I just go and use their lab whenever I need to do orthotic work. Yep. They just very kindly let me, and I might send them. Like I have some people ring up and say they need orthotics, and I explain on the phone that I may not put them down that pathway. I'll just, if they're like, no, I need them, I'll just send them to that practice down there. It's not. I don't want to be just giving someone an orthotic unless they really need it.
Yeah.
And so because when someone says I really need an orthotic, they don't know that. And so that's my assessment might say you don't really need it. And so but who am I to say that to them? If they really want it, then and a practitioner is willing to give it to them, I'm just not that practitioner. My standards are that I won't do it unless I really think that it must be done, and so then if I do use orthotics, I might use form orthotics first and foremost. They're so highly adjustable that I can make as good a customized device out of a form orthotic as any scan. Like answer me this, and one of your posts a long time ago triggered my way of thinking this. We take a scan of a foot that's non-weight bearing with measurements that don't even have any clinical relevance really. And make a prescription on something using a theory that's hard for us to understand, let alone explain it to someone who's going to wear the thing, and is outdated and has poor research-based relevance as well. Yet we do this systemically. We do this like this is a custom-made device, and we even now just take a scan. It's like a totally non-weight-bearing scan. And like I used to just use plaster casts, and then I'd be putting plaster on that plaster cast, and always thought I'm just moving this foot away from being this orthotic away from being customized. So I reckon off-the-shelf devices, if you know how to adjust them, like I've had 2 cases recently. I have a physio that I work really close with. She sent me the first one. He'd had a peroneus longus snapped it and hadn't had it repaired, wasn't going to get it repaired. So really struggling to get the big toe joint down to the ground. And for those listening that don't understand that, the muscle on the outside of the leg wrapping around the base of the outside of the foot is really important at grounding the big toe when we're pushing off. And so this guy is a runner, he's a physio himself, and he's just toeing off laterally and really like struggling. So I used a form orthotic, which I ground down to just as a means to get a 4-foot lateral wedge in to get some weight over to his first. And it's making a huge difference. I've done that twice in the last couple of months. For another guy that had the surgery after snapping peroneus longus, where he's now got it attached to peroneus brevis. So he's still not getting that first ray stabilization from peroneus longus. So we've pushed him down into onto his first with a lateral 4-foot wedge. So that's the type of thing I do now. Or like that chronic heel pain that I've tried everything for Dave, and been really good with their programs that I set out for them and changing shoes, doing all these different things. And we might put a very simple insole in, just almost proprioceptively. Or I had a tib post rupture recently. Like I saw her 3 months down, another podiatrist had not explained things that well to her, and she'd had a scan for an orthotic, but didn't think she'd signed up for it. Yeah. And then when I saw this foot, I'm like, this looks like accessory navicular. This looks like a tib post rupture. You've got to get a scan, because I can rehab this to the cows come home with you. But if those things are going on, it's going to make it really hard. Scan, accessory navicular, and 9mm snap in the tib post. And so, and then when I'm talking to her about this scan on the phone, she's like, the other podiatrist rang up and my orthotic's ready. I didn't even know I was getting one. I'm like, well, now is the time to use that orthotic. Like, I want you not that orthotic until you see the surgeon. And that's a great stopgap to get you through to that point and then we'll reassess. So this is exactly how I use it.
On that, those patients, would you say like that they will probably benefit longer term? And it's such a narrow indication, but would you say that they would probably, and again, not to say they have to, or when we say longer term, it might be for a couple of years. Like, do you think that those are the kind of people that probably do benefit from it longer term in combination with strength and rehab and proper fitting?
So like as in those that perineal songs and tib post, so those types of things, I would say they don't generally ask. They know where I'm coming from and would see it as a short-term thing. But I would say that maybe you'll always use it when you go for your walk every day. But these people tend to love being barefoot or love trying to do less. They're having less coming at them, so they've generally got a goal of not being it all the time. But I would definitely educate them that this might be something you have for certain activities, like it's just all about managing that load. Like, I would hate to tell people they can't walk barefoot on the beach, because most of my clients want to do that.
All right. Can you just say something that I don't agree with?
Oh, no, sorry.
I'm trying to make something a bit polarizing.
Well, can I just say
something wrong?
We chat a lot, or I write a lot, and you send me.
Especially, you're not the only person that says that. I apologize.
That's all right. So, and what I like, I think when I started out doing this way, podiatrists, I just saw it as very black and white. But there's a few of you now that I say, hey, we're doing this stuff, but we're just doing it with the nuance of what you learned 20 years ago as well. And so it's really comforting, or I'm excited about the future of podiatry, because there's people with an open mind, whereas I think the old school podiatrists don't even know that we're having this discussion. Like, it's not even in their heads that it could be a possibility not to do what they've been doing for the last 20 years. And you can CPD till the cows come home. You're not going to hear this stuff yet, but I think the more we talk about it, the more it's going to get out, and then they'll either be forced to change or they'll slowly leave the profession. And, in 20 years time, we might see some different styles of professions. The profession.
Another question, Andy, on the orthotic sort of conversation again. So, for example, someone comes in with like a perineal tendinopathy or something like that, and you decide, maybe not to give them an orthotic. Do you find that rehab timeframes are a little bit longer when you're not offloading it or following, maybe a tissue stress theory, or how are you sort of approaching that?
I reckon podiatrists are often not, in my experience, the first port of call for foot stuff. They're more likely to go see a physio for an ankle sprain, or their GP. And so when they finally get to me 1 or 2 months or 3 months or even more down the track, they're at the chronic stage, and so offloading is not really, I don't think it's really that helpful at that stage. We want to get it more stable, more loaded. And perineal tendinopathies are really interesting. They do really what I'm finding, and this is still kind of fresh for me. It's not like I've got perineal tendinopathy every week, but I might see like 2 a month or something like that. And so, but what I'm finding is that more stable that foot is, like we see the perineals working overtime to stabilize a foot. If you think about what a Bosu ball does to foot stability, it's like your foot is working so overtime. You see the ankle working overtime. And so when we look at a shoe that's full of cushioning, you see the foot working overtime. And so I'll even give I'll give them the choice of going into a cushioned flat shoe that's allowing their big toe to be able to be used, so you can plant it and use it, or go into a fully minimalist shoe. Like, this is one of the cases where going straight to a fully minimalist shoe in a lot of cases is working amazingly well, because they have the ground is firm and their foot is just searching for stability. And so when you have any cushioning under it, the foot is having to work harder. So you're deloading the perineals from doing this like micro movement of stress, and just giving it an opportunity to actually pull on the big toe and work the way it's meant to. So this is just a nuance. There's nothing written up. There's no evidence about this. I'm just finding that it works really well when we just get someone being stable. Heaps of balance work on stable surfaces. Like, when are we walking around on a Bosu ball? When are we doing stuff on a Bosu ball? We're not, unless we're on a really big cushion shoe.
Do you find, like, if the option was there, and I'm guilty of it myself, we were talking about sticking with the perineal example, going into, a shoe that's laterally more stable, and I think of, a Brooks GTS with maybe a lateral wedge or something like that, in comparison to a flatter, more cushioned minimalist shoe, do you see that they get better results with the minimalist shoe because logically it makes sense, a laterally stable shoe should unload that perineal tendon a little bit more, but you're saying that the flatter, more ground contact usually works a little bit better?
Yeah, it does. There's no cushioning. When there's no cushioning, they seem to be able to stabilize better.
Yeah.
But to answer your question more, Kelly, like at the timeline, is it slower rehab? Like I said, often they're a bit later in stage anyway. So, but even in those early ones, like if they are acutely sore, we need to get that under control. And so we're in there with pain, what I call like a little pain management routine of like heat, gentle movement, stuff that's telling their brain this is okay, like ankle rotations, ankle mobility work, foot mobility, some very basic things, and a big plan of isometrics as well, like heaps of that. Like they seem to work really well with my clients for most things, like in terms of pain management. So we're hitting them with all that stuff first to settle it down, and then at the same time changing that environment that's caused the issue often, whether that be load or footwear or work, a whole lot of things.
Yeah, we talked a lot about, and I know you and I talk a lot about this online, and I love it because, I mean, up until 3 months ago, I didn't even really know what the Topo brand was, and now I probably send for 3 or 4 every day, if not one every single day. And I wanted to tell a story about a patient that I had recently who'd had a bit of a flare-up of a 5th MPJ, had been referred to us for an orthotic to wedge laterally, and looked at that, and it wasn't really painful mechanically to test it or to hop or jump or bend the big toe. It seemed more just compressive pain, and thought, it might be, it seems like it's probably your shoe. You've got a pretty wide, flexible foot. Why don't you go and grab a Tobo from one of the local shoe shops? Went and got that, saw him a week later, and I'm thinking, maybe still use your orthotic. We talked about we might use it, come back in, and pain was completely gone. And definitely not saying that happens all the time. However, I would have completely missed that, a complete blind spot of mine, if I had not been probably following your stuff and learning a little bit more about this world. And I imagine all the things and patients that I've missed over the last couple of years where that's probably been the case.
Yeah. Well, don't beat yourself up about that. Like that's the way it is, isn't it? You're always like, I could have done better, or if I'd known this or this, had known. But like the idea of this, and there's a question relating to this that you're probably coming to, of this wide toe box. And that's the way the foot is anatomically designed, to the point that we wear the conventional shoes are not that shape at all. So it's become normal to see a foot is not wide as the tips of the toes. And, that's a baby's foot shape. And then because every human that wears shoes pretty much is in a shoe that compresses the toes, the normal foot shape is now a compressed toe shape. And so for me, like in a minimalist shoe, we're looking at it being thin soled, so that so you can feel the ground, and I see that as negotiable. Flats from heel to toe, that's negotiable depending on what we're trying to achieve with a client. Flexible, so the foot can move. Again, negotiable depending on what we're trying to achieve with the client. The first one, which I skipped, is wide, and that's the non-negotiable for me. Like your toes, have to be able to move. And I know a lot of people are like, what's so big about the toes moving? The muscles of the foot are attached to the toes. If you're not going to be able to move them, how are the muscles of the foot going to function properly? And people like wriggle their toes in there, squish. This is not toe movement. Natural toe movement is the ability to splay. And there's a physio in Finland who's obviously aligned, part of our community, as you call it. She's got this little video of her, and I've posted this, of her like 2-year-old walking and looking down at the foot. And as the heel hits, before the heel hits the ground, the foot is just at rest, basically, and then the heel hits the ground and the foot just does this splay, just spreads out and accepts the ground and presses down onto the ground, and as it pushes off, it springs up again. This is what's meant to happen as our foot moves every time, and if our toes are like this all the time, that's going to have an effect. Whether that be how that relates to pathology, I have no idea, but I know
things like that.
So much stuff. Yeah, so much stuff. And so that's my non-negotiable in terms of footwear. It's got to be wide, which relates again. And so that relates again to another question that you'll probably come to is like, where do I go with the plantar heel pain? And are they all going to minimalist shoe? Like, that would just be suicidal in terms of my career to be putting people with heel pain. And it wouldn't make me feel that good either. Like, generally, if I'm making people hurt more.
Yeah.
Although maybe it would be like shockwave therapy. The pain would be so bad you'd forget about some other pain or something.
Yeah. Kelly's good. We'll shockwave her shins a couple of times, and we can only do it once because she hates it. She can only do it after.
That's right. Well, same. My son got some warts on his knees when he was about 4, and I used liquid nitrogen on them. I would never freeze another child because anyone ever again. Because like when I'm seeing my own son in that much pain, I'm like, I can't do this to anyone else anymore.
Yeah.
So like I would then definitely use some cushioning in a shoe, maybe even a little bit of a heel lift to take some load off. Yeah. But definitely we want to be able to splay those toes so that we can get some good blood flow, good movement in the area, you know?
Yeah. And I think, and again, we talk about a lot online now, I think about it, because I feel like I'm starting every question with that. I tend to think, and I'm just going to talk from my own experience, that, you know, with footwear, I think a lot of people, just from a lack of knowledge of specific shoes and what to recommend, probably don't know a lot about which shoes to recommend in the minimalist category. And I was just mentioning before, like Topo and Ultra, but if you were to ask me a work boot, I only know one, Wide Load, found them a couple of months ago. And in the ladies' shoe, I couldn't actually tell you any category at all. So what do you think, general categories, where can people go, websites, and then how do you kind of educate them about the shoe itself?
So there are 140 barefoot shoe brands at the moment. So this is a massive industry. Yeah. And I mean, I don't know how many normal shoe brands there are, but 140 barefoot shoe brands, and they're popping up all over the place. So because there's such a demand for it. So there's in social media, there are great resources. The best is Anya's Reviews. This is a woman in America who has listed every, like she's as far as feet go, a lay person, but through her own experience, and then is obviously entrepreneurial enough to set up a business, but has become quite knowledgeable. I would suggest more knowledgeable than a lot of podiatrists when it comes to natural foot function. And so, you know, you can go to her website, Anya's Reviews, and see your foot shape. Like she's listed the 6 or 7 different foot shapes, whether it be like a long first toe, all the different foot shapes, and then go from there, and it goes through each, like whether you've got a more mobile foot, how to test for it, a more stiffer foot, and these are the shoes that will suit you, and this is like the shoe for you, you know, because it's not one size fits all. It's not like, okay, everyone should be in Vivo barefoot. They're so popular because they've got a huge branding and huge spread across the world, but they tend to be the most narrow and shallow of all the barefoot shoes. And so they suit some feet, but not all feet. And I could say with my clients, I would say 90% of my clients that come to me for me to talk to them about a musculoskeletal issue, they have wide feet. They have wide compared to normal feet. So I'm seeing a part of the population that is more affected by conventional shoes. If I was seeing 90% of people with really narrow feet, they're going to be far less affected by conventional shoes, obviously, because a narrow foot fits in a conventional shoe more easily. But yeah, I'm definitely preaching to that group of people that are struggling to ever fit their shoes on.
And are you pulling out the sock liner and just showing them? Because sometimes it can definitely be hard. We joke in the clinic, like where fashion meets function, you've got to meet in the middle because everyone doesn't want to wear what you recommend. Do you just pull out the sock liner and hold it to their foot and say, you know, you can see the issue quite clearly. Yeah. It's probably why I think you need to go in this shoe.
I did that yesterday with that lady I was talking to you about. I don't often do that. I'll show them how the big toe is meant to work as a hinge, and then I'll say, look, your toe's in this angle, and if you're in this shoe, and this is where the hinge is meant to be, look at the angle that hinge is on when you're functioning, you know, like, so I show them that a lot. Yeah, like I said, I see a lot of people that already know this stuff or are understanding and they want to get into this stuff, and so they've got a foot problem and want to go this way rather than traditional way. But for podiatrists out there listening that aren't seeing that population, it's and thinking that a wide shoe is going to be better, just think about how that big toe is meant to act and how important it is. And then, is that actually happening in the shoes the person is wearing? Like, it triggers, using that big toe triggers a positive effect all the way up into the pelvic floor when we push off. And so if we're not using that big toe properly, we are missing out on a whole chain reaction of events in the normal human gait that are, like, I almost think it should be a movement all about the big toe, really, rather than, like, it's about having that big toe working. We gave up the ability to use our big toe as an opposing digit to be able to stand up straight. And then we put shoes on it that pretty much render it not working. How many people are actually wearing out where their on their shoe where their big toe is? You look at nearly every runner's shoe, they're wearing out second, third, fourth met heads. They're just low gear toeing off with every step. Yeah. With its multitude of effects. But the human body's amazingly adaptable. So, because the argument is, well, not everyone's got foot pain, and most people are wearing these conventional shoes. We adapt. Our bodies are amazingly adaptable. Doesn't mean they're functioning as well as they could.
And so, like, moving on from shoes a little bit, like, how else are you managing your patients? Is it involving some sort of like intrinsic strengthening or some sort of strengthening, or what else do you do?
So I'm assessing them first to see where the red flags are that I might call, and my language about this is very important. Possibly almost one of the most important parts of how I consult is speaking to someone very positively about their feet, because a lot of people have very negative connotations and ideas about their feet that have been set up from a very young age, whether it was grandma saying you had flat feet, or the podiatrist saying that you need orthotics for the rest of your life, or you've got this foot type which is has negative connotations. So straight away, I'm assessing someone and explaining what I'm seeing while I'm assessing, explaining how I assess, so that they're part of the process and they're feeling what I'm saying. They're able to experience what I'm saying. And that might be like, look, you're one of the best shock absorbers I've ever seen, like, your foot is shock absorbing beautifully. In the past, we'd be like, wow, look at that foot, it's rolling in so much, we got to stop that,
Yeah, how are you still alive? Look at that foot.
That's right. And then, but hey, look, when you get to that point where your big toe hits the ground, we want to see you pushing off more efficiently, and that might be something we can work on. That we can be stronger in that, and this is how we're going to do that. Let's look how mobile your ankles are. Like, why are you so efficient at shock absorbing, and why are you less efficient at pushing off? For example, I'm just using this is the lay terms that I use. Okay, is it a mobility issue? Let's work on some mobility. Is it a strength issue? Let's work on that. And then I tend to try not to overload someone with exercises and rehab. Like, they're going to get exercises and rehab when they see me, but I don't want to give a list of 10 exercises. I'll tend to give them 3, a very foot specific one, an ankle specific one, and a hip or a whole body specific one. And then maybe just a little piece of gait retraining as well, like something that helps them use their foot in a different way, or walk in a way that is going to change load on the thing that's sore. And so,
what specifics with exercise, like in regards, I mean, we all know short forward and doming, and this is only my opinion. I don't think that, depending on the population as well, and obviously seeing different, I don't think arch doming does enough, because it's not enough of a stimulus. Like, what progression can you do for people once they get over, I guess, that part of using it?
Yeah. So Sportsmith did a post the other day from some guy in France that had said specifically, you see all these people lifting their toes and doing toe yoga and using bands on their toes. Like, please, our foot is so strong. It has to do this thousands of times every day. A few little bands aren't really going to cut it. And so that's what that post was saying, and I totally agree. Like, I will test if someone has the connection to be able to use their brain to move their feet. But that's just like asking someone if they can flex and unflex and extend their arm to be able to do a bicep curl. It's going to take a while to get big biceps if all you're going to do is just move your arm back and forward without some load or bigger stimulus. And so doming, Like short foot, I would hardly. I don't think I've ever written it in my notes. I might use it as part of that. I said I do a foot exercise, integrate it into a calf, like an ankle exercise, often a calf raise variation, and then integrate that further into a whole body movement. And I would have someone short footing without me even mentioning it, when they're just like, I call it conscious standing, for example, where I'm getting them aware of where the weight is in their foot. Like often in heel pain, they're standing on their heels, like 90% of the weight's on their heels. Or often, short foot will be a part of that, where I'm giving them a cue that will bring that about, but understanding load. And that will be like step one. Step two will be like challenge, that's just with 2 feet. Step two will be doing it on one side. Step three might be, challenging the balance and then loading the balance with a hinge or a squat pattern. So we're getting hip controlling over the foot and integrating all that together. So that's like my progression for whole body exercise. I just get someone everyone stands like waiting for coffee, brushing their teeth, all these different times. We're loading our feet in a way that could be, I think is probably conducive to their injury with like probably hundreds of minutes a day, if we can have some effect on that time.
Yeah.
And so the benefit of the barefoot shoe, or the shoe that doesn't affect your foot, gives you this ability to tune into what's going on with your feet. You can actually start feeling what your feet are doing and then adjust your body accordingly and then make a habit of that. At the foot level, so like, again, that's a foot exercise, but I integrate it with the whole rest of the body. At the foot level, in terms of intrinsic muscles, I think I tend to see, generally speaking, overactive extrinsics. And so we really want to settle them down. And again, that could be a balance exercise that really tries to calm that ankle movement, that rapid ankle movement, and really try and fire up the intrinsic muscles of the foot, like a long flat toe, pressing down. Like even the idea of this the toe exercises where you're lifting your toes, the lifting really is only beneficial to not tripping over when your leg is swinging through the air.
Yeah.
Like it doesn't have much functional effect as we push off and power through the foot. So we really want to only lift it so that we can push it down. So depending on the issue, I'll be focusing on trying to fire up the and I hate the word, but activate the intrinsic foot muscles of the intrinsic foot muscles individually as required, or wholly as required, depending on the situation. So hardly ever would I actually prescribe towel crunching, because it bypasses the intrinsics and just fires up the extrinsics. Yeah. And I know that doming and towel crunching are the go-tos for podiatrists to do foot exercises, and I don't teach either of them. So I'm really focused on intrinsics, and then calf raises. Like nearly everyone gets a variation of calf raises. We turn that into a gait retraining thing as well. Yeah.
How are you testing if someone has, overactive or underactive foot intrinsics versus extrinsics?
Yeah, great question. I challenge myself with this very, very regularly. So you can see whether they've got overactive extrinsics, because you see toe clawing, you see imbalance, you see the ankle moving at 1,000,000 miles an hour when they're balancing. And if you think about what your ankle, the extrinsics should be doing, they're meant to be creating some stability, but they're kind of meant to be a spring, this on and off, load, unload, load, unload. And I think our intrinsics are meant to be creating some stability within the foot, and doing it like it's not black and white. So I'm just visually seeing how that's going. Often it might be a niggly Achilles, or it might be one of those extrinsic muscles that's painful. So you'd expect that might be overused if it's painful. I have the little card from Michaud that does the dynamometer testing. Yep. And I saw that test totally butchered by some people, what people would say, I'm not mentioning names, but at the forefront of foot rehab and strength recently. And I'm like, if this is what people are doing, they're actually testing the extrinsics, not the intrinsics. And that test is all about the intrinsics. And so I find the test fiddly and frustrating, and someone's going to get better at it because they practiced it a week ago, like when I saw them last time. So I know it's research based and has got a really good background for being legitimate, but I struggle to use it because I find it fiddly and annoying. I'm going with how their foot feels, and how well they can flatten their toes. Like I said before, the forces involved in using those intrinsic when we're walking, running, or moving are so great that I think it's hard to measure. It's more of a okay, this is the issue, as in this is the diagnosis. If we hit intrinsics, they're going to get stronger. That's going to have an effect, basically. So very clinical, as opposed to research. Yeah.
Do you find when you're seeing people that are in pain, and we know people in pain, rightly so, can be, they just want to be out of pain and they just want help with their pain. I mean, these things typically do help. Do you ever find, and I know some of the worries with clinicians is doing this rehab or movement, they're concerned that they could just flare them up or make them worse. How do you kind of educate, I guess, the patient about that? And we know it's inevitable. You will have flare-ups with rehab. It's more trying to manage the flare-ups. Do you find you see that clinically, and then how do you educate your patients about that stuff when they're in shoes and exercise and things like that?
This is the most difficult part of the job. This is why I take such a long assessment, because you've got to find where someone's at in terms of where to start the rehab. And so I think your assessment should be about finding out where they're at. So that's your starting point of rehab, or if they're really flared up at that time, to regress it to this point, or if their skill level in the assessment is not high enough, regress it so their skill level when they get back to that point is better. So it's about to start with, and I'm getting better at it, I think, finding where they're at, and then it's also giving instructions well. Like I told one guy to do a certain amount of calf raises. He did 3 times as much. And I had to focus on using the big toe. So he almost gave himself sesamoiditis, over a 3-week period. Like, this is like, whoa, really didn't communicate that well. I better get better in that sense. It's not his fault. It's a communication issue. So then we managed that. So, but I tend to not see people really quickly. Like this, I start out by saying this is a long, slow process. In fact, one of the first things I say to people is your body's probably got this. In a year's time, you're probably going to go, I remember that heel pain I had. Like if you look at the research, natural history is going to be looking after this. What we're trying to do is make you get over it quicker and stop it happening again. That's what I feel you're here for me. I'm not going to fix you. I'm just going to give you the tools to hopefully get over it quicker and stop it happening again. But, if you go and try and run a marathon, you only have to run 10K, this could happen again. So I'm educating people to reframe why they have the pain and what the rehab's going to look like as well. So then if they have a flare, and then when they leave, I say every time, just use me as a resource. If you're not sure about something we spoke about in an hour's time, send me a text and I'll reiterate it, or I'll explain it in a different way. I'll send you a video of me explaining it. If you're not sure if you're doing the exercise right, and I'm not going to see you for 3 or 4 weeks, I don't want you doing it not correctly for 3 weeks. I would rather you ask me if you're not sure, like and I saw someone 3 weeks ago. I'm seeing them in 2 weeks' time. Yesterday, they sent a message saying, my ankles are flared up. I did a huge day on Sunday, 20,000 steps, moving house. Do you think it's because of that? She sent me an email. I rang her and it's like, one, I'm really glad that you could put those 2 things together. Like the fact that you're now recognizing when you did that, this is what the result was, as opposed to, my feet are sore again. Why? Like to actually put those 2 things together. And so I'm really glad that you've done that. Like that's a big step for this person. And then secondly, these are the things that I think you should do over the next few days. And she's got a pair of hockers from a previous podiatrist, and she's like really inflamed. I'm like, today is the day to wear your hockers, like wear your hockers for a couple of days. Because that's going to help you settle your feet down, and then we slowly integrate back into your rehab. And I'll see you in 2 weeks' time. But call me if you need to. Basically,
that's good. What do you think the conventional podiatrist and physio over here can learn from your treatment philosophy?
Like I would, it's not. It's not about what shoe. It's a little bit about what shoes to wear, but it's mostly about saying, okay, how's this human body meant to move and meant to function naturally? And let's give it the best environment to do that. So there's a whole lot of that, rather than what do we have to add to this problem to make it better? It's more like, what can we take away from this problem? How can we manage this so the person comes out the other side a more resilient person, not needing a whole lot of stuff, not needing to see their chiro every week for like an adjustment. How can we make someone more resilient out of this process? Like I'd say that's a really important thing to have in your mind. But also to spend time listening to people, if they could just hear people out. My initial consultation's an hour and a quarter, and at least the first half an hour is just hearing what someone has to say and asking a million questions. Like some people even say, wow, you ask a lot of questions. Like I'm asking about so much detail about their day-to-day life, because that's where the answers are, I think, in terms of and finding out where they're at, you know. So and I have the luxury of that because I'm in my own clinic. I bill the way I want to bill, and I'm busy. But if you are in a clinic that's only letting you have like half an hour initial consultations or less, like it should change. Like you need to have time to spend with someone, especially if you're busy, because if you only had half an hour and then you couldn't see them for a period of time because you're so busy, like over the next few weeks, it's like it's going to be a real struggle to hear what they have to say and find out where they're at. And you know, 3 years ago I'd be like like I said before, all about the shoes, but now it's mostly about the client, like making it a client-focused treatment and meeting them where they're at.
Yeah, I think that's really good. And like I totally agree. I think so much of how we can provide value to people is just by listening to them and knowing that they feel listened to. So yeah, I totally agree. I'm throwing you like a bit on the spot here, but where are we sitting at the moment in the literature around minimalist shoes and foot intrinsic muscle strengthening and things like that?
I love Luke Kelly's work. He's up in Brisbane, I think, where he found that, like, the idea of the intrinsics was that they held the arch up. I think initially that's what we used to think, but then he found when he anesthetized the intrinsic muscles, the arch didn't change. There's no change in arch deformation when the intrinsic muscles weren't working, but the stiffness of the foot when the intrinsic muscles weren't working changed dramatically. So we know the intrinsics are critical to that stiffening, that pushing off phase of walking and running, probably. And so there's plenty of research there from his work, I think. Would you agree, Blake? I don't know.
Yeah, I would definitely, and it's only getting better. It's good because it's such a hard area to research. But you're right. Yeah, his work.
And so, I mean, when you look at that in terms of plantar heel pain, if the plantar fasciitis is under too much load and degrading and getting, getting sore because it's being overloaded, then it makes sense that if the intrinsics aren't doing enough work, then the plantar fascia is going to be doing more of the work and getting sore. So how do we get a muscle to get stronger? We make the joints that it's crossing move. And what do most conventional shoes do? They stop the joints of the midfoot moving as much as they could. They don't stop them moving totally. We know that. We know that a stiff shoe is not stopping your foot moving. An orthotic is not stopping your foot moving either, but it's changing the way it's moving. And when you wear it for 30 or 40 years, it's a very long, slow, I think it's a very long, slow degradation in the way the foot is meant to move. We've seen some research showing a whole bunch of people put one in a Vivo or in a minimalist shoe for 6 months, put the other one on foot muscle exercises, test their muscles at the start, test their muscles at the end of 6 months. Just wearing minimalist shoes is increasing muscle size. The naysayers will say, oh, that's because the muscles are less efficient. And so a smaller muscle is more efficient. It's still doing the same thing. That's like saying Arnold Schwarzenegger is not efficient at lifting something, you know, like a bigger foot muscle tends to be a stronger foot muscle, more cross-sectional area, that type of stuff. So there's research there. I don't know how good the research is. I'm not an expert on that.
It's pretty good. Like I would challenge people listening to this to go out and have a real look. And obviously you're never going to have perfect research, but I'm not going to sit here and lie. I remember prepping, in the years and talking with people and like yourself that are probably a little bit more polarizing than what you are, and going and looking at the research myself and going, oh, far out, it's right again. I go, great. I won't talk about that one because it's right. I'm trying to find the ones that sort my stuff. But it's good. And we know, yes, bigger muscles don't always correlate to stronger muscles, but there's got to be some give and take somewhere. So
if you have a bias, you can find some research to find your bias. So that brings us back, and this is what Nick probably taught me from the Foot Collective, to the first principles of how the body is designed to move. And really, we should be testing what a conventional shoe is doing in a negative way to the foot, rather than going, where's all the proof of minimalist shoes? Like the the foot is designed to not have anything on it that changes its function. And so it evolved that way over many, many years. And now we're saying that that's not the best way. We're saying that what we add to it makes it better. And so I have a problem with that. And with every other part of the body, we can find tons of research that show that strength and conditioning is the gold standard for rehabbing an ankle, for rehabbing a knee, a hip, a back, a shoulder, a neck. Strength and conditioning is ticking the box. When we come to the foot, we go, let's support it. We had something, heel pain. It was like a continued education thing here in Melbourne last year. Heel pain, support or strengthen. And it was looking, and it had 3 podiatrists talking about it, and they were saying, and looking at individual case studies. And at the end, they all went, support it. We need to support heel pain. But all of the cases had degraded with more and more support, and to the point where one of them snapped, as an AFL footballer, snapped his plantar fascia, because it had been unloaded for so long, you know. So the foot is seen as some anomaly, and the research in every other field is showing that it's not. I don't do any manual therapy in every, and this is another huge can of worms, I should say. Manual therapy, like we've got all these foot manipulations and all this type of stuff, and I'm sure it feels good, but really, is the human body designed to need someone else to look after it? You know, it's not really.
Yeah, I completely agree. The FMT crowd, I would have to, it's ridiculous. Grinding the ankle, like, why do you need to do that? Just get them to do a calf raise, you know.
Yeah, make it stronger. This is it, stronger. Yeah, or teach them how to do it themselves, and they can do it 10 times a day rather than come and see you 3 times a week. And maybe they won't be as good at doing it themselves, but each time, but they're doing it 10 times. You're equipping them with a tool that when they've got a stiff and tight ankle, they go, oh, I remember that. This is what I need to do, rather than having to go back and see someone over and over again. It's a terrible business model, but it's a powerful educational thing. Yeah. Go on, Sarah.
What do you know?
Going to ask. So I think a lot of what we're talking about is sort of, you know, building general capacity for a day-to-day sense. But what about when we talk about performance and specifically running? I would say that
I agree.
Not much denying the fact that there is a role for the super shoes. Would you agree?
100%. And I know Blake is a huge fan.
You can't blame me. When I put that thing on, I feel like Elliot Kipchoge. I don't run, but I feel like him.
You're as tall as him, but there it ends.
I'm probably that extra 60 kilos, but
maybe your haircut's similar as well, I'm not sure. I look after Sonia O'Sullivan, who's a world-class athlete in the past, and she says that she puts that shoe on. It's like someone put her someone's pushing her from the small of the back. And she says she goes to park run, and the guy that ran 25 minutes is now running 23 minutes. So this is an amazing tool, you know. When I see elite athletes, so I saw a guy who's an elite sprinter, master sprinter, and he can like blow the charts away in terms of calf strength. And so there's no way my little calf strengthening exercises and my little haphazard plyometric programs are going to hit it. But I've got a great referral network here. And so I'll send them to like a great physio in the city, Nick Rees, who can test and measure.
Yeah. You know, Nick, cool.
Like he's a really good friend of mine who can test and measure. And and Luke Nelson is a chiropractor that just is down the road. And Michelle.
All the hub there. There's all those guys I follow on Instagram.
And so Luke is great. He sends me all the barefoot research whenever he comes across something. He's sending me this good stuff. I'm like, thanks, mate. Thanks, mate. I have to put in these tabs that I've got open there in case someone asks me a question. Anyway, so I've got these people that test and measure far more than I do. I'm dealing with mostly general population, and teaching and saying go to look up Couch to 5K if you want to run. I've got I use a program for running for technique called Older Yet Faster, which is a guy in Sydney who's like a world-class 65-year-old athlete and who's really designed barefoot running. Like he's got a great program. But then we've got Paul McKinnon here, the balance runner, who I went to for a lesson myself. He's like the world-class running technique type of person. So when it gets to elite athletes, I'm saying you can use me. I've got a really good ability. Like, I don't want to blow my own trumpet, but I've got a good bullshit meter. Like, if someone's saying you need this treatment over and over again, I'm like, you know, you got to find someone. So use me as a resource. I act as a resource for someone like that. Bounce stuff off me. Make sure, you know, keep your other practitioners honest by coming and having a chat to me, type of thing. So in elite athletes, I often send them out to some extent. Or I might say, you know, I give them programs to be doing stuff when they're not in their super shoes, you know, like it's like when I used to be an elite cyclist, I would train on a bike that was maybe maybe half again as heavy as my race bike, because it was probably a good training effect. It was, it lasted longer. It didn't affect my performance. If anything, it might have increased it, but I'd go to my race bike for time trials, for good training sessions, for you know, for races, obviously, similar to a shoe that elevates the heel when someone's squatting. Of course, you're going to want to train with it if you are going to compete with it, if you're a power lifter or Olympic lifter, but you're not going to, I would say it's not ideal to walk around in a heeled shoe all the time if you're a power lifter or an Olympic lifter. You should be getting some good ankle range of motion yourself. And you'll see these guys, they don't have ankle range of motion issues. They're not using that shoe to get over an ankle range of motion issue. They're using it as a performance thing. And you see Kipchoge, he's using that shoe to increase his performance, not because he's got a running technique issue or because he's inefficient in his running or because he's got a weak foot. He's doing it to get to use it for performance. And so I'm all for it. In fact, I even bought a pair of cushion shoes so that I could run 10K as fast as I could. I didn't buy it.
What one did you get? Oh, are they big white ones? You need to get a pair of the Vaporflies, mate. You'd probably take 20 minutes off your 10K with that.
My 10, no, I can't go that much faster.
To the limit, you're at the ceiling. Oh, that's good.
So I got a pair of Ultra Escalantes to run. My brother-in-law wanted to run a slow marathon, and I was going to keep him company. And I'm like, this is going to be a long time in no cushioning. So I got given those shoes to just do that. But then he bailed, and I was really happy because it means I didn't have to do it. Not because of the shoe thing. I didn't want to run for 4 hours.
Yeah. You got any runs coming up? Any races?
I'm having a break. I did a whole trail running series over winter, and you know, like my body gets sore because I've still got a bit of athlete mentality. I raced one instead of just running one, and I was sore for like 3 weeks. My feet were sore because it was really rocky, and when you're racing instead of watching where you step, and the guy in Hocker's flying past me, just like running on a cushion, and I'm like trying to pick down this rocky path, so I'm like going for it. I had sore feet for 3 weeks, you know, like it's but I would say that's a human experience, and that's what I'm about, as opposed to going as fast as I possibly could. Now, I'm 45, you know, so.
One question I wanted to ask, and I've saved this one to last because I think it's an important one, is how, like, transitioning, if someone's coming, you know, to, you know, any podiatrist and, you know, they don't have access to someone like yourself, how are you recommending, and we'll use 2 examples of someone with an orthotic in a shoe where, you know, we'll use heel pain. They've had a heel pain, they've had heel lifts, compression softs, taping, soft inner soles. It's gotten better. They feel really good. Then it's like, great, you don't need this inner sole anymore. How can we transition them out of the orthotic itself? And then also, if they want to go to less of a shoe, how can we do that? What education, what recommendations are we giving? Because I think and I'm talking definitely for myself, the fear is it'll come back, or I'll flare it up again, or that kind of thing.
So the education starts from when you put them in it, so that they don't have an expectation it's going to be there all the time. So talking about that, and then this is why I go to the lab up the road, because people come to me and they are reliant on their orthotics and they don't want to be. So my brief is to help them get out of their orthotics by making their foot stronger, making them move better, and to decrease the control of their orthotic. And so I tend to put them in a shoe that's going to help their big toe work, because I think an orthotic works. Like, I reckon we used to think the orthotic helped the most at slowing down pronation or changing pronation, which we know it doesn't do that so much. I think they work more now because they create stiffness from the first MPJ to the heel, so you can toe off with something that's quite rigid and help you be more efficient at pushing off. So we've got to work. So I've got them doing exercises to be better at efficiently pushing off, like a ton of calf raises, heaps of intrinsic foot strength stuff, like localized. integrating into gait retraining, like actually walking in a way that's going to help them push off through the big toe. And then I'm slowly decreasing their orthotics. So I grind out the medial arch of the orthotic, or grind out whichever. And so it starts out rigid, and then it softens and it softens. It's not actually changing shape, but it's becoming more mobile. Yep. Because the amount of people are in a really stiff device, which I know, like your generation of podiatrists are using far less the stiff device.
Yeah.
And then I'm explaining it, like, they could be in it for 3 or 4 years, but then I think they're working more proprioceptively rather than changing anything. And I'm even saying to the person I put in it for that chronic heel pain, this is going to work proprioceptively. We don't see that it's changing angles. We're not seeing it changing movement. We're just seeing that the fact that you've got something up against your arch is changing the way the muscles in that area and the way your body's moving. And so therefore, if you're also working on their movement patterns and strength, it's an easy sell, if that's what you have to do, to say that you don't need the orthotic anymore because you've slowly weaned them off. Like, I've got one person who's weaning off orthotics over the last year, another one 2 years into weaning off orthotics. She comes in every 4 months, and I might drop her down. But this is someone that was in a hocker and an orthotic at 28 because of a turf toe injury that was poorly managed. Yeah. And told you will be like that for the rest of your life, chronic pain syndrome, and so
that's
2 years later, she can walk. Part of our Feel Good About Your Feet program is to go for a barefoot walk on the grass because she loves it, to to get up in the morning and not put your feet straight into your shoes.
Yeah.
We've got her orthotic now out of the hocker and into a minimalist shoe. So the orthotic it's all about the orthotic now. We're just weaning, just dropping that down. But it's, again, finding somewhere where they meet and just working them out of it. And most podiatry practices would have the grinding machine. It's a 30-second job, I even just pick up a pair up. One guy, I pick them up on the way to work and drop them off on the way home on the days that he decides is helpful for me to do that,
Yeah. And then footwear wise, is it, hocker down this end and then, the barefoot down this end? We know that people are going to be at different ends, but probably better they're further down the other side to the minimalist end.
Yeah.
Where, do you just transition them from shoe to shoe, like lot to cushion to moderate to less to whatever? Or how do you do that? If they want to go to the less of a shoe?
COVID here in Melbourne was a perfect storm because for 2 years, people didn't wear shoes at home mostly. And so they've either gone back to their shoes and had pain, or they had pain because they were out of their shoes. And so, just walking barefoot, they started getting pain. So I'm assessing how much they're barefoot anyway, what shoe they're in, how well they function and how much they're relying on that shoe in terms of, like, if I'm watching them walk and watching them move and seeing, wow, that they are relying on the shoe a lot. It's going to be a lot slower process compared to, and this is that history that I'm taking, finding out what they're wearing, how much they're moving without shoes on anyway. Like, some people are 90% of the time without shoes and then hockers for 10%, and they want to get into a minimalist shoe. It's like, that's an easy transition. They're already without their shoes most of the time anyway.
Yeah.
And also how much they want to get into a minimalist shoe. Like, some people don't want to, and that's totally fine. Like, I'm not here to tell everyone to go in a minimalist shoe. I'm here to help people get to where they want and where they're happy with, like, some people I see want to be in minimalist shoes and do a whole lot of barefoot stuff. And so we have to work a bit harder to get them there. But others are just wanting to get out of foot pain. And so you just put them in an Ultra or a Topo with a 4 mil drop. And they're like, where have these shoes been my whole life, And others don't want to change their shoe. And I'm educating them around rehab being a stopgap. But, I would say that they're probably still going to run into problems further down the track.
Yeah. All right. We didn't really disagree on much at all. I didn't feel like I knew this.
Well, that's why I find it so promising to talk to you, Blake. So thanks.
Yeah, I appreciate it. And we'll post this in the show notes as well, but I messaged you maybe a month or a couple of weeks ago asking for a couple of different shoes in the categories, and you sent through some Instagram pages and things. So we'll put that in the show notes for people, because it was just a lack of knowledge. I just did not know. They're saying, what's a good latest shoe with plenty of room? I go, I don't know. I just didn't know. So it's good to have a good, and like you said, a pathway to even send patients to their Instagram page to have a look, and then they can order offline, off sizes and things. Yeah,
and they're designing, they're like styling them as well, these pages. They're like going, look, cool. You can look like this in this heel, but look, I look like this in this shoe as well. So it's quite handy. There's this whole movement around it. So I think we talked about it being a real blind spot of podiatry that this is not being talked about. It needs to be like, I've got a dream, and whether it happens, maybe you can help it happen. Where, third-year podiatry students get given a pair of Vivos at the start of the semester, and they have to get themselves into them. And how good a project would that be? And each week you're doing some looking into the different aspects of what being in a minimalist shoe is as part of your lectures, but they're actually going through the process themselves, not so they all become podiatrists like me, but so that when a client comes to them and says, I want to get into these shoes, they understand it. Because right now, most podiatrists are saying no.
Yeah, exactly. It seems either they don't want to, or they believe in the old model, or it's lack of knowledge, or and I've talked about this with multiple podiatrists over the last week, there's the people that have started podiatry, the best, most logical, smartest biomechanical podiatrists in the world, and they don't understand this stuff, or they've never practiced it, so they don't recommend it to anyone. So it's like you never get to hear it from people other than people like yourself. So it's
the running shoe boom was also the boom of podiatry in the 60s. Like that's when we put heels and cushions in, and that's when people started running as a recreation as opposed to being athletes. Before that, they were wearing minimal shoes just about as athletic shoes. Yeah. And then podiatry came about, the biomechanics came about, orthotics, and it all came into this thing that is podiatry. And so it's still a relatively young science. And I think we've got a great opportunity to go give us 6 months of a student's life and let us have an effect on them so they understand natural human foot function better than any other health professional.
I feel bad because I'm about to go and run in my Vaporfly 2s, which are the
I just told you it's okay. I've told you it's okay.
Yeah, that's right. And we always joke because my feet, and this is, I don't think I've ever actually told this live on the podcast.
He's got some ugly feet.
But Dusty Ward, if you're listening to this, so a friend of mine, he had size 10 shoes, and he got a second set sent to him because the place had sent him the wrong pair of shoes. Anyway, he got another set of shoes, and he goes, "Oh, do you want them?" I said, great. I bought him off him for $50. I'm a size 11.5, and I wore these size 10s. And now I have like actual PIPJ and DIPJ deformity. And everyone ripped something like, "You're a podiatrist, your feet are meant to be perfect." But I train barefoot, and I run mostly in minimal shoes. I don't run in minimal shoes, but I train barefoot, and I do try and do some movement stuff like that.
Can I say, Blake, the most important thing is the shoe you wear to work every day. You're in that shoe for 40 hours a week.
This is the thing. That's why I'm in a pair of RMs.
Yeah, shocking.
What shoe would you recommend for a work boot? Because it needs to be protective because we're dealing with scalpels and things like that. And I know you wear barefoot to work, and I can't do that.
So I just wear whatever minimalist shoe I've got on. Yeah. But I dress very casually for work these days. The Vivo have a beautiful RA. Yeah, RA. They've even got the RA Luxe, which looks really shiny as well. Yeah. And then there's Prime Trotter, which is this beautiful brand in the UK that make a beautiful boot that is actually foot shaped. Because you could do all the training at the gym barefoot. You could do all the toe exercises you like. If you're wearing your RMs for 40 hours a week, it's like you're just like no point.
But then I don't have, and I've got the RM belt to match. So people won't think I'm cool if I don't have double RM. I'm actually going to get a pair of those. And if I get pain, I'm coming to Melbourne. But that's good. So, and that's that same thing, just lack of knowledge. I didn't know. But I see the value in it. So we'll see. Mate, thank you so much for coming on. I know you've got a patient now, but super appreciate it. And mate, we'll talk soon.
Thanks so much, Andy.
Thank you.